Welcome to the Mayo Clinic Cardiovascular Continuing Medical Education Podcast. Join us each week to discuss the most pressing topics in cardiology and gain valuable insights that can be directly applied to your practice.
Hello, my name is Dr. Steve Kopecky. I'm a preventive cardiologist at Mayo Clinic in Rochester, Minnesota. It's my great pleasure today to be speaking with Dr. Princess Brewer, a assistant professor of medicine and preventive cardiologist also, who's done some really fascinating research in healthcare disparities. Welcome.
Thank you so much for the invitation to be here today and to share with you about our research.
Great to have you. So tell us, Dr. Brewer, what are health disparities?
So great question. So it's important to distinguish between health disparities and healthcare disparities. So health disparities are differences in the incidence, prevalence, mortality, burden of disease, and other adverse health conditions among specific population groups, whereas healthcare disparities are differences between groups in healthcare coverage, access to care, and quality of care. And these disparities basically limit our ability to achieve health equity. They also limit improvement in overall quality of care and population health, and they lead to unnecessary healthcare costs.
Interesting. So you mentioned a term there. Could you define it for us? Health equity. What is health equity?
So health equity means that everyone has a fair and just opportunity to be as healthy as possible. And it's also a state where all people have the opportunity to reach their full health potential without any imposing structural barriers.
Mm-hmm. Very good. So there's a lot of press lately about social determinants of health. And can you expand on that a little bit? Tell us about it.
Yes. So COVID-19 has truly unmasked several pre-existing health disparities and structural inequities. And there has been now a focus on the social determinants of health. And they're key to promoting heart health and preventing cardiovascular disease. And they're defined as conditions in the environments in which people are born into, live, work, play, and pray and worship that affect health outcomes. And it's also important that we recognize that 80% of what affects a person's health lies outside of the clinical or medical setting. So it's more than just excellent clinical care that influences health outcomes. And the social determinants of health can have a positive or negative influence on health outcomes based on a person's access to resources or advantage or disadvantage. And some of the examples of the social determinants of health, or also they've been known as the social drivers of health, are economic stability, which includes access to food and housing, as well as employment opportunities, access to health care, education level, neighborhood and the built environment. So having safe parks and recreational activities, as well as social and community networks. So these all are drivers of our health outcomes.
So you mentioned that 80% of our health does not depend on our health care, which is very interesting. And I always thought it was more 90%, to be honest, but that's a fascinating statistic. And how do you separate, and we can't separate these things out, but there's the socioeconomic and then the racial and ethnic issues, and they're so overlapped and so intertwined. How do you try to separate those out, or is there a difference even?
Yeah, so it's really important that, not only do we look at differences in different populations based on their race and ethnicity, but I think it's also really important that we delve into more than just race and ethnicity and kind of look at kind of what are the structural barriers that these groups or special populations are experiencing. So racial ethnic minority groups are more likely to have lower socioeconomic status, have decreased education opportunities, and also are faced with discrimination and racism. And all of these factors can certainly influence health outcomes.
So a lot of our health depends on our choices, but you have to have good choices you can make.
Exactly. That's a great way to put it.
Now, Dr. Brewer, you have done, I know, some fascinating research and in the communities and in the Twin Cities and here in Rochester Can you tell us some about that and what you found out?
Oh, thank you. So my research focus area addresses cardiovascular health disparities among African Americans through community-based interventions. And our program, the Faith Cardiovascular Health and Wellness Program, is the first academic community partnership between Mayo Clinic and local African American churches and community health centers. And FAITH stands for Fostering African American Improvement in Total Health. And we integrate a community-based participatory research approach with our research in that we involve community members at all phases of the research process, from conceptualization of the research question all the way to dissemination of research findings. And our focus has been promotion of heart health through the American Heart Association's Life Simple 7 framework, which are 7 key things that we can all do to prevent heart disease. And they're health promoting behaviors as well as maintenance of ideal factors such as your blood pressure and cholesterol. And our programs have included health education sessions in person at African American churches delivered by Mayo Clinic health professionals, which you have been a part of, and we've been gracious to have you a part of our program, as well as those within other departments. It's been a collaborative effort. And we've now expanded to include mobile health interventions, and we developed a community-driven or vetted digital smartphone app called the Faith app to promote heart health as well. And also during the COVID-19 pandemic, Faith has truly had to repurpose itself to not only focus on heart health, but also wellness during this time from a spiritual and emotional and physical health standpoint. So we've partnered with African American churches to increase their emergency preparedness within the pandemic through a social marketing campaign, through social media, and email blast. And we also partnered with a community health center in St. Paul to establish a drive-through COVID-19 testing site. And we've served over 4,000 patients. So it truly shows the power of community collaborations and how it can truly address not only the social determinants of health, but also be a service to the community.
Oh, that's fantastic. That really is. And it's been very well received, I know, by many of the churches here in Rochester. What have you found? I mean, what can we really do to help these health disparities?
Yes, I really think that it takes an earnest and sincere effort to truly meet patients where they are, to understand what their needs and preferences are when you're developing interventions to address health disparities, whether it's intervention for a patient or an intervention for a community. So I think we also have to look at it from what we call the socio-ecological model. So these are key spheres that influence our health. So you kind of look at the individual level, you look at the systemic level, the community level, and then how can we intervene on each of these spheres to improve their health outcomes.
Mm-hmm. Oh, that's great. Do you have any outcomes data that you've looked at yet?
Yes. So with our pilot study of the smartphone app, the Faith app, we had participants follow a 10-week intervention using the app. And on the app, there were key education modules on heart health through the Life Simple 7 framework. And the education modules included succinct short videos from Mayo Clinic health professionals. And after the 10-week intervention, our participants had improvements in cardiovascular health. So they had a reduction in their blood pressure, so both systolic and diastolic blood pressures, so 6-point reductions. And under both prior and new hypertension guidelines, this remains statistically significant. As far as health behaviors, they had an improvement in their diet. They were reporting eating increased fruits and vegetables, and they doubled their physical activity over the course of the intervention. And lastly, I mentioned that we're using the American Heart Association's Life Simple 7 framework. And through that, there's a score that we calculate to measure your cardiovascular health or heart health. And our participants moved the needle. So they went from intermediate all the way to ideal or excellent cardiovascular health
Oh, that's fantastic.
in
That's
their
just
Life Simple 7 scores.
wonderful work. So in closing, what can you tell a practitioner when I go into my next patient and they don't look like me? What can I do? What can I do to help?
Yeah, so I think especially during this time when we're all faced with so many different burdens and challenges during the COVID-19 pandemic, I think it's really important that we understand and just even recognize the social determinants of health and what people are experiencing outside of the clinic, because you can give them a nice clinical plan, but you also have to consider the conditions in which they live in order to be able to accomplish those. So I think it's really important that in our clinical encounters, we ask about these things. So, ask about their access to healthy foods. Do they have housing? Do they have an ability to even get to your appointments? So I think that's really important for us to all be a part of achieving health equity for our patients.
That's a great message, Dr. Brewer. It's been a pleasure to speak with you today. Thank you for your insights.
All right, thank you.
Thank you for joining us today. Feel free to share your thoughts and suggestions about the podcast by emailing cvselfstudy@mayo.edu. Be sure to subscribe to the Mayo Clinic Cardiovascular CME podcast on your favorite platform and tune in each week to explore today's most pressing cardiology topics with your colleagues at Mayo Clinic.